time it is. Marvin Devine, Huber, Axel, and you know how we do.
Yeah, I got the juice. Whip game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof.
You already know what happens when we link up. Let's go.
Yeah.
Good morning, good afternoon, good evening. Welcome, and I sincerely mean welcome to another episode of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Welcome. I got to adjust my hat. Hey, this is live. Anything can happen. But welcome. And thank you for tuning in for another episode, again, of Kidney Hub East Africa. Today, we're going to discuss a topic not only that our brothers and sisters in East Africa and beyond use, but people here in the United States, United Kingdom, wherever you're watching, right? Wherever you're watching, can use the tips we're going to talk about today. And here, back again, and we're really appreciative of her, is renal nurse specialist Tabitha Matekwa, all the way from Nairobi, Kenya. And let's not forget, we have my other co-host, Brother Moses Kennedy, also known as the Kidney Ambassador. So before I bring our two guests on, let me just give a quick announcement that, hold on, a quick disclaimer before we get started. And here's that disclaimer. Kidney Hub East Africa. The information broadcast on Kidney Hub East Africa is provided for educational purposes only. Well, let me repeat that. For educational and informational purposes only. And is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. So with that being said, let me bring on my co-host all the way from Kisumu, Kenya, Brother Ken Moses, also known as the Kidney Ambassador. Brother Moses, welcome. Your mic, we can't hear you. Your mic.
Can you hear me?
Yes.
All right.
Welcome, Brother Moses. Welcome.
Thank you so much. Thank you so much, Brother Steve. I'm glad. I'm really super excited to be here today. And we are glad. I am glad that the discussion will be helpful to people around this globe, and especially those who are new on dialysis and or are about to begin dialysis. So this is a topic that is less discussed, but we want to expound it. We here right now we have experts. So kindly feel free and drop your comments and questions. Thank you so much, Brother Steve.
Absolutely. Thank you, Brother Moses. So let me bring on our featured guest. We definitely welcome back again Tabitha Matekwa, all the way from Nairobi, and we definitely got to give her a special introduction. So let's do that now. Hi, Tabitha. How are you?
Hi. I'm fine.
Welcome, welcome. How are you doing today?
I had a very good day today. I went to church, then I was back home. Thank you. Yeah.
Again, thank you for joining. We got some people here. P Teachers always here. Thank you, P Teach, for joining. You're always a great supporter. Thank you for coming by. And Victor Penzon 4740, all the way from Panama. Thank you for watching and welcome. Welcome. We appreciate you coming. So this topic that we're going to discuss today, I don't know if we'll be able to finish it. I hope we will in the allotted time. But Tabitha, you work in the field, and you most likely see new people who start dialysis.
Yeah.
Who never been on dialysis. This is their first treatment, and they don't know what to expect. I'm sure you ran across many patients like that.
Many.
Yes. And I'm sure, Brother Moses, by you being a kidney warrior, you have experience starting off being a dialysis patient. So this is what we're going to discuss for people who may be watching that are about to start dialysis, their family member, their loved one, and they don't know what to expect. And a lot of times people don't get this type of information. They just go into it blindly and they find out along the way. So as we start off, number one, let's talk about what hemodialysis is. What is outpatient hemodialysis? And hemodialysis is a procedure that filters waste, excess salts, and fluid from the blood when the kidneys are no longer working well enough to do that. Outpatient hemodialysis means a person comes to a dialysis clinic or hospital, because there's places overseas where people not only go to an outpatient center, but go to a hospital 3 times or 2 times a week. Now, these sessions normally last about 3 to 5 hours, commonly 3 times a week here in the U.S., United Kingdom, but as we see in parts of East Africa, there's 2 times a week. Brother Moses, let's start with you. By you being a kidney warrior and been on dialysis, what, about 10 years now?
10 years, yes.
Okay, you've been on dialysis a decade. When you first started dialysis, did you know what to expect on that first treatment, or when the doctors came in and said, Mr. Kim Moses, we need to start you on dialysis therapy? Did you know what to expect once you got out the hospital and went into your very first outpatient clinic? Did you know what to expect?
Absolutely. I didn't know what to expect because, Brother Steve, I didn't know in the first place that how serious the condition was. And basically, my case is a different story because I didn't expect anything before. And then, I was wheeled into dialysis and I went to coma. And after 2 weeks, I begin to recollect. So I was able to get information from my nephrologist and basically the entire team. And there was absolutely nothing to expect before I was wheeled or after, because there was that lack of knowledge. You only know that your kidneys are not working properly, and you do not know actually the consequences or the entire journey that will be after diagnosis. Back to you, Brother Steve.
Thank you, Brother Moses. Nurse Tabitha, when you see new patients starting dialysis, are you seeing them in a hospital or at the clinic?
Mostly it's at the hospital. It's actually at the hospital. They come to dialysis, yes.
And so when you see someone start for the first time, do you have patients asking you questions? Are they scared? Are they silenced? Can you describe to the audience what you see on an average, the usual patient who start dialysis in the hospital in Kenya for the very first time?
Okay, because most of the patients don't seek medical advice on time. Many of them come when they are very, very sick, and some of them may not even be able to understand as we counsel them. So sometimes we even start with the family, and maybe later we explain to the patient why we had to initiate treatment. You can find patients who come even with a creatinine of 2000. They've just come because they are feeling like the body is not well. But for those who have been on regular follow-up, especially those who visit conservative, our clinic, we call it our renal clinic, they are managed, and when there is decline in function of the kidney, they are sent on time for counseling. And when they come for counseling early on time, I first explain to them the function of the kidney, the way it eliminates waste. There is BP control, bone health. Also, it helps in maturation of the red blood cells, and again also to remove excess waste and even excess fluid. And now the doctor has said your kidney function are declining, and you are likely to start dialysis anytime from now. And if the doctor tells you now this is the right time for you to start dialysis, this is what to expect. We usually insert catheter up here or down here at the femoral. And when we insert the catheter, this is what we do. The doctor usually puts some lignocaine so that you don't feel pain at the site where he's going to insert the catheter. Then from there, once the catheter is there, we usually put a bandage. So for those who are on conservative management, you're able to explain them early enough. Yeah.
So, Nurse Tabitha, let me ask you, for patients who know that they have kidney disease and the kidney doctor been following their care, do they look at the medical history and do an assessment, do blood tests and things like that?
Yes, they do. For those who are on regular follow-up, if they've not yet even started dialysis, once there is decline in function of the kidney, of course, there is regular checkup of urea, electrolytes, and creatinine, and full hemogram. We also do for them HIV, hepatitis B, and hepatitis C, because for hepatitis B, we separate, and they are dialyzed on an isolation room. So we cancel them early enough. Yeah.
Mm-hmm. So, Brother Moses, back to you. When you got out the hospital, or before you got out the hospital, did somebody come to your room and tell you or ask you, almost like here in the U.S., it's called a case manager, that will come to the person's room before they get ready to get discharged to find out where they live, so to see if they live close to a unit that the doctor visits or have privileges at. So for you, before you got discharged to go home, did anyone come to you, like a nurse or someone from the hospital, to say, okay, this is the clinic you're going to be going to? How did you know what clinic to go to when you was discharged from the hospital?
Well, on a day of discharge, I had my nephrologist over there, and basically nephrology nurse was around. There were two, and I also have a psychiatrist, because I lost memory. So there was also a psychiatrist to do a follow-up. But then what happens is, after being discharged, we discussed a few things with the doctor, about hours that will be taken on dialysis, and then some few drugs was given for protect me from infection, antibacterial drugs, and then I was showed to come again for dialysis on the same week. That was on Tuesday. So I was discharged on Monday, and then on Wednesday, I was told to come and continue with my dialysis. So when I came in the first time alone, without being taken in by being taken in by caregiver, I got used to now the system because I'd accepted that this will be the way out because we had discussed. So I had accepted that this is the way out, and the only survival, my life will now definitely depend on machine. But during that particular time, my doc really convinced me that it will be a shorter period of time. Then I got more of an impetus to keep on without missing, because I knew that good health will come out of it. So when I was able to breathe properly, I began to had appetite, and general health wise, I would say I started seeing some changes, and that is how it picked up from that moment. And now I ended up working in center dialysis alone and getting out despite all the conditions. Yeah, so basically that is how it happens in my case. But because of the busy nature of the care team, kind of they are overwhelmed. We never had much time to discuss about so many things. However, I was given the basics, say the minimum irreducible that would guide me throughout when I'm out. So it forced me to get into reading materials now. This is how I developed passion in kidney disease as a way of also understanding my condition. So yes, that was it, Brother Steve.
Let's answer this question right here by P Teach 9957. Asks, how are caregivers or family treated on first visit? Are family members allowed in the center? Tabitha, have you ever worked at an outpatient facility other than the hospital?
Okay, our hospital, our unit is inpatient stroke outpatient. So we allow the...
Have you ever worked at an outpatient clinic in the community other than the hospital?
Not really. I've been in the hospital, but our units function like outpatient and inpatient. Yeah, okay. We did with both, yeah.
So can you answer this question? How are caregivers, family members treated on the first visit when they come there with their loved one who's been diagnosed with kidney failure and they're doing dialysis therapy right there? How are the family treated? Are they given information? Are they being educated about what's happening?
Yes, first of all, you find out who has come, so that you are not dealing with outsiders. If it is the immediate family members, you tell them, you update them on the progress of the patient. You also help them understand that the patient's kidney has failed, and this is how the results are. If it is a creatinine, whichever level, and I let them know which are the normal levels, and their patient's creatinine is this much. If it's a HB, the same. Now, what we do not reveal, if a patient has HIV, the patient has to give a consent for that. But then after we've explained to them now what is happening, I tell them about the function of the kidney so that they can understand why the patient really needs dialysis. Then after I've explained to them the function of the kidney, I will tell them the doctor has recommended the patient requires to do a dialysis, and what is exactly is dialysis, where we need to remove as much waste as possible from the patient, and we are going to insert a catheter, and where we are going to insert a catheter, whether it is up here or down here on the femoral, and the way they're also going to help the patient take care of that catheter, because it's also, the bandage needs to always be there. And again, also we tell them the catheter should not even be used somewhere else. Then I will tell them you're going to start with the first 3 sessions today, tomorrow, and the 4th day. After that, the patient, depending on if it is acute or chronic, if it is chronic, most likely they're going to be dialyzing twice a week, unless maybe the doctor has recommended a third session. And maybe after the first 3 sessions, the doctor may discharge the patient home. So they should not expect that when the patient is going home, the catheter is not we are going to pull out the catheter. No, we tell them the patient is going home with a catheter, and immediately after discharge, remember, the patient needs to continue on dialysis even next week. After 2 or 3 days, the patient needs to come for dialysis. Then I also ask them, where does the patient live? If the patient lives nearby, we can recommend them to come to our center. But next to our center, we have so many dialysis, like almost more than 20 centers. I tell them because of influx of patients from different centers, because of when they have issues they need to be sorted, they can get a center where they will feel comfortable, and I just give them I just tell them, here you can get a center, here you can get a center. If it is at home area, like here we call them counties, I tell them, in your county, Murang'a, there is dialysis. If it is Kisumu, there is dialysis. You don't have to move from Mombasa to come and dialyze in Nairobi. So I give them that option to make a decision, and then so that they can help their client to make a decision on where to dialyze. Then I tell them, whatever was the primary cause of, whatever was affecting the patient before they started dialysis, they should not forego the other clinics. Let's say if the patient was diabetic, if the patient had an orthopedic issue, if the patient had a surgical issue, they need to continue with those other clinics as the patient continues on dialysis. After that, I tell them, on discharge, there is dialysis to continue too. There is also a clinic, because we also run a dialysis clinic. Like in our unit, we run a dialysis clinic on Monday. It doesn't matter where a patient dialyzes, but they come for review by a nephrology doctor, where he's able to review them and find out how they are, refill their prescription, or that then they can go back to whichever center they have chosen. So I tell the relative to do that. And again, also, I request them that they need to make sure before the patient leaves, the patient needs to be seen by a dietitian, so that they can be told on how to manage fluids and the diet, because the patient has just recently started on dialysis. Thank you. You're mute. Steve, you're mute. Unmute.
Okay, thank you. That was a lot. Are many of patients, do you see many patients being overwhelmed when they first start in the information they receive? Brother Moses, were you overwhelmed when you first started in the information you received for dialysis?
Oh yes, oh yes. Definitely. You get overwhelmed. You get worked up. You begin from nowhere, and it's like you are ending nowhere. You keep on thinking, what next? How you want to maneuver through all that demand, and then you end up just having a no answer in definitely everything. So you get overwhelmed. Honestly, you get overwhelmed to the point that some people, if you don't work accordingly onto your mental health, then it's possible you'll go crazy. It's possible you'll go crazy if you don't accept and own that now this is the reality. This is the norm of life, my new norm of life. So, of course, yes, you will be overwhelmed, Brother Steve.
Okay. All right. Thanks for sharing that. So for let's move on. Many people may be watching this and wonder what happens during the first dialysis session. So let me describe what happens here in United States, as I've admitted many patients on dialysis throughout my career, working in dialysis. While one comes in and they're sitting in the lobby or the patient waiting area, first thing that normally happens when you let people know that you're there, in a lot of places you start filling out your admission packet, and that's giving us consent to do the treatment, vaccination, HIPAA forms, advanced directives, and assignment of benefits, meaning assigning the insurance to pay for the labs, the treatment, and any other documents that patients' rights and responsibilities, and let's say any other documents that need to be signed that is part of the admission packet. All right, admission packet has different forms that need to be signed when one becomes admitted to a outpatient facility. Once that's over with, if you're still sitting in the lobby, now it doesn't have to happen after they sign it, but normally they need to get orders from the physician to find out what type of filter you on. You get heparin, whatever the orders are. They setting up the dialyzer, getting ready for your treatment. Once they find out, okay, you signed the admission packet, you're sitting out there, bring you back. So when you come back, for most patients, they come in, they get their weight, okay? You walk you back, introduce you to your technician, go where you're going to be sitting. We're doing vital signs before they start dialysis. They should be taking your blood pressure, temperature, We already got your weight, your pulse rate. They get you ready, you're in the chair. And most of the time, people who first start off in outpatient has a catheter. Let me see if I got it. This right here. Most patients start off have a catheter. And they clean it, got your weight, they figuring out how much they're going to remove from you, start the treatment. A lot of times that treatment lasts anywhere from here in the United States, here to 4 hours. In Kenya, I know it's 4 hours twice a week. And during that time, while you're doing your treatment, you are being, or you're supposed to be monitored. And here in some places in the United States, they take your vital signs every 30 minutes. Some places is every hour. Nurse Tabitha, can you discuss, since you said that the hospital runs more like an outpatient center as well, how often are vital signs taken? And when someone new starts, is there supposed to be a nurse assessment done before the patient go on the machine? I forgot to mention that here in most places, in most clinics, when the patient first starts, before they get on the machine, the nurse has to do an assessment before they start treatment. Can you discuss that first day when the patient signs? Do patients sign forms there and then you start the treatment? Can you elaborate on that a little bit?
Yeah, once the patient come, let's say like maybe he's just come for dialysis, or maybe it's the first time, we check on the labs, the urea creatinine, potassium levels, also the full blood count, because you also want to check on the HB, the white blood cells, any infection, so that maybe after the dialysis, maybe the patient might require maybe an antibiotic if they had done a previous lab of the full blood count. But you really need to know the current HB, hemoglobin level of the patient. Then the patient will be weighed. You want to know the previous weight and the weight today and the difference. Or maybe like if it's a new patient, you start it like, now this is the weight I'm starting with. Then you also need to assess the head to toe examination of the patient, and you need to see if there is any signs of edema, maybe on the eyelids, maybe on the chest when you auscultate. Then you can also check on the pitting edema of the lower limbs, and even on the heart scan. Do you tell you that if the patient has really added a lot of weight? The blood pressure is done, and the temperature, the pulse. Then again, if there is any pre-dialysis prescription by the doctor, you can check on it. This is where the pre-dialysis prescription is about the amount to remove the pump rate. Then the heparin amount. Some patient may require less heparin, or depending. Again, also the loading dose of heparin, and again the amount of fluid maybe that you also need to remove. Does the patient also require antibiotic? Maybe the doctor has prescribed, so that maybe after the session, maybe the patient may need, let's say like for example, a vancomycin, something like that. Then you set the machine and you start the patient on dialysis. For our first session patient, we do 2 hours. or maybe if the doctor had prescribed a slow dialysis, it will depend on how many hours. Maybe for that one that is slow dialysis, even the pump rate might also be less, not like the way we do the others. Yeah. And then we make sure that every hour you're checking on the blood pressure of the patient, as you also address issues as they come in. Thank you.
Right. So it's every hour that they monitor the vital signs there.
Yes.
And just to follow up, are family members allowed in the clinic on the first day? If they come to the hospital to visit and their family member going to dialysis, are they allowed to go to the inpatient center with their loved one and sit by their side?
Okay, what we do, especially when I'm doing counseling, I prefer to also take them round to see the machine so that they can also actualize what we are really talking about. When you're talking about the dialysis, when you're talking about the catheter, they can now see the reality even as their patient is dialyzing. But they can visit and then they wait. They can see the patient on the machine and then they wait at the waiting bay.
So they can't sit there with them. They had to go, they could come in and stay for a minute and then go back and sit in the lobby and wait for them.
Mostly because of infection prevention. We also don't entertain a lot of crowd because of infection prevention. Just for a short while, then they go back and wait at the sitting bay.
Mm-hmm. Mm-hmm.
Yeah.
Brother Moses, let me ask you, when you got out the hospital, and this is going to have to be a two-part show because this is a lot. We're going to have to finish the discussion next week. But Brother Moses, when you got out the hospital and you started your very first outpatient clinic, can you walk us through what that looked like? Your very first time going to outpatient hemodialysis. Was it what you expected? Was it something unknown? Were you nervous? Did you have any anxiety? Can you walk us through your very first session at an outpatient facility?
It's really a mix of a lot of things, from anxiety to I mean, it was a mix of so many things, because in the first place, things are happening that beyond your imagination. You know, when science is at work, sometimes you might think either you are dreaming or you are seeing some form of miracles. So when I went in as an outpatient, the first day as an outpatient, my first dialysis, I was so confused in the sense that I saw nurses coming over, checking vitals. I was green, I was naive. I know basically nothing, you know.
Mm-hmm.
I felt like I want to pee. I'm asking myself, I mean, what will happen now? Do I need to tell the nurse? You see, it was operating completely on a no idea. But then slowly, I started having some confidence towards my health, and inquiring from them jokingly that what is this, what is that, you know, and I could be answered. So interest grew, and each time I would ask, why do you do so? Why do you clean the bed? Why must we wash our hands over there? I mean, so it was slow, but a slow process, but progressively, it made me change my attitude towards treatment, and I reaffirm myself that this is how now I'll have to go this way. If this is what I have on my way, I'll have to go this way. So, Brother Steve, I'm telling you, it was total confusion. Total confusion, because remember, I had mentioned earlier, I also had some memory loss. So most of the things were not operating quite normal. It was then later that I began to recollect what was happening. I would ask my mom, what is happening. I would ask maybe a close friend who is there, what is happening, you know. And that is how I got encouraged, especially with my support system, and I moved on, Brother Steve. Yeah.
Wow. Okay. All right. Well, thank you for that, Brother Moses. So let's talk about some common sensations and side effects during your first treatment. And again, you have people who we call quote, quote, crash into dialysis, meaning they go to the hospital and they're sick, and then they find out that they have kidney failure. And then you have people that were managed, that know that they have it, and the doctor's been managing them, but the symptoms has come to a head, and now they have to start some type of renal replacement therapy. Now, when you go out center, I'm not talking about the hospital, but when you start out center, and even a hospital, but where this discussion is mostly talking about outpatient hemodialysis, when one goes back to back, and even if you're watching this and you're not on dialysis and you got kidney disease, or if you don't know, you got diabetes or hypertension, and you do have to, if you do end up in the hospital, but you haven't gotten there yet, these symptoms that I'm about to talk about, apply across the board, meaning people go into the hospital and you get treatment, or people who are outpatient. Now, you often hear many people say that they feel tired after dialysis. Fatigue can be strong on the first day because most people still are uremic. And so that first day, if you got fluid on, you're still uremic, you can feel drained or tired after the first treatment. Another side effect, dizziness or low blood pressure. And this is common when fluid is removed, because the theory is if you have on a lot of fluid, as we pour fluid, your blood pressure is supposed to decrease. That's the theory. It doesn't always happen. All right. It doesn't always happen because you have people who have essential hypertension where their blood pressure is elevated throughout the treatment, no matter how much fluid you try to pull off. Now we're trying to address this through medicinal purposes. But Some of these side effects that can occur, as I mentioned, feeling tired afterwards, dizziness, muscle cramps, which often is in the legs or the back, can happen in the abdomen. Again, everybody's impacted differently. Nausea, vomiting, headache, chills, or fever. And if that happens, if you just starting and you watching this broadcast, and if you get any type of chills or fever, make sure you let the staff know that right away. Itching could be from uremic or high phosphorus. Also, if you just got a catheter placed in, you're going to have some discomfort at the site. Brother Moses, we're going to go to you, and then we're going to talk to Nurse Tabitha. When you first started dialysis on that first day, did you experience, or not just the first day of outpatient, but even in the hospital, did you experience any of the symptoms on the first day that I just talked about? Fatigue, dizziness, muscle cramps, nausea, headache, itching, access discomfort. Did you experience any of that on your first day of treatment?
Yes. First of all, I almost experienced basically everything from except muscle cramp. But then dizziness was always there on a top notch every day, basically. So dizziness, nausea, there was also a lot of nausea that I used to experience. And then just the entire body, I got fatigued. So in most cases, after treatment, I would be guided, then taken care of until I get home, because there was so many things that was affecting me during those days, the first few weeks, because I remember it was vomiting, it was nausea. I mean, it was just basically everything. I remember at one time, I even again lost memory, and then I need to be admitted. Then I'm not sure how it was handled, but then the following morning, my doctor came and I was seen, and I was told that I had some memory issue that will restore with time. So yes, it's an experience that many warriors go through, but then in different ways. Each patient, different ways, Brother Steve.
All right. One more question, Brother Moses. Has there ever been a time when you first started that you thought you were the only person going through what you were going through?
Just come on from your last statement.
I said, was there ever a time when you first started dialysis that you thought you were the only one going through these symptoms?
Absolutely. There is a song that says that sometimes you might think that it rains on you alone, and it excludes your friend. So those were the moments when I was mesmerized in a way, that how comes it's me and not others? How comes it happens? this serious condition with serious consequences. It's me, why, you know? And these are things you just grapple with slowly as you get along, Brother Steve. I remember even when I went to Kenyatta Hospital, then I didn't even plan to meet Tabitha. But then when I met her, she was able to take me to all corners and whatever manner of protocol that was needed to get my services. So basically, it is just one day at a time. One day at a time, Brother Steve. Yes. Back to you.
Sorry. Okay, I got Nurse Tabitha. Knowing that you see patients on the very first day that they start treatment, do you see many patients on the very first day coming into the renal unit experiencing the symptoms that I discussed, the side effects like dizziness or low blood pressure, muscle cramping, nausea, headache, chills or fever, itching, or them complaining about pain at the catheter site? Have you seen this in real time?
Yeah, I've seen it. I've been there for a long time, for quite some years, and I can tell you there are those who experience low blood sugar. Sometimes they will say that they are not seeing well. You just know, and if you check on you do random blood sugar, you'll find that the sugar is down, and this is where we give 50% dextrose. Some of them, they will feel a little bit dizzy. When you check maybe the blood pressure, maybe it has dropped. Just as simple as infusing some little saline, maybe like even 200, 200 mils, the patient will be up. There are those who will start saying they are feeling chills and fevers, and we just give some medication. And there are those who complain, who will even vomit, all manner of, just the way you are talking about those issues. It is true. Some of them will even experience some headaches. When you check on the blood pressure, maybe it is quite high, and you just administer antihypertensive, and it really relieves them and helps them, or even give with a combination of paracetamol, and it really works. So it is real. Yeah,
Wow.
I remember there is a patient, after giving 50% dextrose, she felt like it was hit on the body, and she was like, "Have you disconnected the machine?" And then we told her, "No, we have just administered 50% dextrose." So there is something that they usually feel if you push very fast. There's that sensation that they feel. Yeah.
Mm-hmm. Brother Moses, we're gonna talk about one more thing that happens on the first day, what to expect. And then next week, we lost Brother Moses, Tabitha, so he should be back. But as I was mentioning to Moses, that we're going to talk about one more thing that happens on the first day of outpatient, or what happens during a typical hemodialysis session. And then we're going to return. Are you able to return next week?
It is all right. I can. Yeah.
Yes. And next week we'll finish up. But what I want to talk about is after the treatment. So we talked about what happens pre-dialysis when they come. We talked about what happened during dialysis, their treatment, and we got Brother Moses back. We talk about what happens during treatment. Now we're going to talk about after dialysis. And Brother Moses, can you hear me all right?
I can hear you.
Okay, what I was saying was we're going to finish off with this last topic pertaining to what happens during hemodialysis. And then next week, we're going to finish off with the second half of normally what to expect during your first outpatient session. So what I was just about to get into was after the dialysis session. So we talked about pre-dialysis. Come in, fill the form out. We're waiting to start. Now you come in, you get your weight, you get your vital signs and the labs, and clean your exit site, your weight. Then you run your treatment. You may or may not have side effects during the treatment. And we talked about the side effects: dizziness, low blood pressure, cramping, nausea, vomiting, itching. Now we're talking about post-dialysis. In the field, we call it post-treatment or after the dialysis session. And what normally happens technically is pretty much rechecks, meaning we're going to check your weight to see if we took off any fluid. We're going to check your post-blood pressure, your pulse, your temperature. That's going to be taken before you leave, because if you drive and you stand up and take a blood pressure and your blood pressure 80 or 70 over 60 and you dizzy, we ain't going to let you drive. At least I'm not going to let you drive. And if you say, I'm leaving anyway, I want to give you an AMA against a medical advice. And you're like, man, I ain't signing that. And you walk out, only thing I'm going to do is put on it right on the bottom, patient refused to sign, and sign my name. So I don't get no liability that I let you out. But we do this to prevent situations like that, or someone leaving and your blood pressure is below your baseline post-treatment, and you out there on the city bus or somewhere going home, and we know, and I don't even live in Kenya or East Africa. We know it's hot as blazes over there. Brother Moses then talked about it, that it can get hot. And who wants to be out in the sun after finishing a hemodialysis treatment, having anywhere from 5 to 10 pounds of fluid poured off of you, depending on how much fluid they have to remove? So here's what happens in most cases after the dialysis session is we're going to do rechecks. We're going to weigh, see what your weight is. We're going to do your vitals, blood pressure, pulse, temp. Over in East Africa, they may have diet and medicines. The care team may tell them how much fluid they can take before the next session, and any diet changes that they may make, or like potassium, salt, protein. Some medicines are held or given at dialysis. And you got to confirm with the staff about this. And as Brother Moses said, many medicines that are needed to correct certain issues like anemia, phosphorus or bone, or iron deficiency has to be paid out of pocket. And we're going to address that in a second. Also, after treatment, once you finish and you go out to the lobby, I don't know how they have it in Kenya, if they have a transport service where they pick patients up and take them home, or you're responsible for your own transportation. Here in the United States, they do have paired transport companies that come and pick patients up, take them home. Metro Access, MTA are some of the ones up here in the DC, Maryland area. And then maybe over in East Africa, they may have a follow-up to come back for regular sessions. Here's the same way. Once you go for your first session, we're going to let you know. Got to come back. So you start at Monday, come back on Wednesday, Friday. Your schedule is now Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Nurse Tabitha, if I can ask you, after like the post-treatment, do patients have a way home? How are they getting back to their residence?
The family and the caregiver, they organize how the patient will go back home. It is the responsibility of the family. Yeah, we don't have organized transport.
Okay, Brother Moses, how are you getting home from treatment?
Let me just speak on my own behalf and perhaps other kidney warriors. Transport being a challenge, especially those who are in town. It's a challenge in that you have to sort it yourself. We have people with no families, or in other words, relatives around to take care of their bus fare. So it's purely upon the patient to get to know how he gets to the unit and then back home. And interestingly, when I know in US, Medicare takes care of or refunds for the bus fare, but then in Kenya, sometimes it is transportation to the facilities is one of the most hindrance to access to treatment, dialysis treatment. So it is a serious problem here. It is basically a serious problem here in Kenya, and I guess East Africa as a whole. So you have to take care of it, how you get back home and come next session. And you know what? Our care team also has no hand on this, because everyone is basically struggling. You get to talk to one patient from the other. Basically, everyone is struggling. So the government doesn't talk about it. It is something that It is purely left for the family and your immediate next of kin. Yeah.
Tabitha, is there, as we kind of winding down, is there a high rate of patient no-show at outpatient facilities in the hospital, patients that may come to the hospital for treatment? Is there a high rate of mistreatments as a result of transportation issues?
Quite many. There are quite many. And when you ask them, they tell you they are not able. And especially there are those who lose their job. And once they have lost their job, they now depend on these other people. And if the bigger family has not come in, as in the extended family are not able to come in and support them, you will find them missing, or maybe when they come to the facility, they don't want to leave. They just want to hang around and until now the next dialysis day. Then after 2 sessions, they go home, miss 1 or 2 sessions, come and hang around the hospital. It doesn't matter where they sleep, whether they will sleep or in casualty or wherever. Then they show up for dialysis, but they have not gone home. And when they go home, there's a session they miss because of finances. So it's quite a challenge for many of them. I remember there is one who also used to live in the street. And it's like, anytime she would come, it's like she's home now. This is home, away from home. And
Wow.
then now when she's able to come for dialysis, she just stays. It is quite sad. Sad. Yeah.
We're going to definitely finish this discussion next week. But one thing I want to ask you, Tabitha and Brother Moses, is the practice of reuse being done in Kenya? And what I mean by that, chat, are these filters, are they being reused, taken in the
Not
bag
really.
and put
We used to have we used to do a reuse, and we used to have a way of cleaning them and reusing. There are those particular dialyzers that were very good for reuse, but I think over with time, maybe they miss the whatever was required to do the reuse, so we no longer do it. But there are time we really benefited, maybe like for a 1 year or 2 years. Yeah.
Brother Moses, are they doing this in your facility?
No, to be specific, in my facility, we even encourage them to line the machine when the patient are around, because yes, they don't reuse them. But I heard sometimes back, most facilities in Kenya used to reuse. But as I speak, I'm sure most of the clinics don't reuse them. They don't.
Okay, that's good. Here in the United States, they don't as well, but they used to very heavily. They used to use it. So, but next week, when we come back, we're going to talk about practical issues specific to East Africa, how they decide dialysis dose and fluid removal, risks to know, questions one should ask on their first visit, practical checklist to bring to the first session, emotional and long-term considerations, and final points and safety reminders. But one thing I want to ask you, Brother Moses, before we leave, Brother Moses, did you have any question to ask on the first day, or did you know any questions to ask on your first day of dialysis, or you were pretty much quiet?
Basically, on my first week, I had nothing to ask. I was absolutely just there to be treated and go home without caring what has happened, what they are doing it to me, and then you just want your time finished, then you go home, because you know how sometimes a new thing becomes so tedious. Like sitting there on that chair for 3 hours, it became so tedious to me that sometimes I would not even sleep in the first place. So to me, it was very slow and tedious process of treatment. So I never asked any questions the first week. Yeah.
Brother Moses, one more question I want to ask before we kind of head on out. I know you in multiple Facebook groups, and when you may see comments of some people in these groups saying maybe they skipped treatment or they did something against they were medically advised to do, or say if they say I don't take my binders, I throw them away, or whatever the case may be. Have you ever looked at some of these comments and said to yourself, maybe these guys are what's the word I want to use? Are wasting precious resources because of the lack of resources that they may have in Kenya, meaning, for instance, binders and other medicines that you would need to address the side effects of your disease. It could be helping you, but you got to come out of pocket. But here in the US, you have people who may quote look like they abusing the system because they getting, like you said, they getting Medicare, but they're not taking full advantage of those services.
Oh yes. I've been to so many groups, and number one, I normally like a comment just to do a follow up if that comment triggers so much about knowledge that I still want to follow up. So I will definitely like the comment so that it keeps on coming. But then I've seen quite a number of them, even in UK. I've seen people. I've heard them having excess of drugs that we so need here in Kenya, and instead of making good use of that package, they in a way abuse it. Just like Medicare in US, I know people has a lot, especially anti-rejectory drugs. anti-suppressant drugs that really most of Kenyans toil to have. I've seen some saying they have, including expired drugs, meaning they are not making use of it. So yes, you get to see that scenario whereby everyone, what people lack on one end, the other end, it is kept until it becomes trash. So yes, Brother Steve, those are things that are there. I want to give you a very good example. Today, if you are diagnosed with mineral bone disorder, then the drugs that really nephrologists would want to prescribe are not there even when you go to the highest level of hospital where nurse Tabitha works. You will realize that they are never there in stock. Something like sinacalfate, it is a drug that is really good at fixing bone mineral disorder if you are given by your nephrologist. But then what happens if you go to a facility, you won't get that kind of drug and then end up still digging deep onto your pocket. So yes, there are such scenarios, Brother Steve. Yeah.
Yeah, thank you, Brother Moses. Nurse Tabitha, anything you want to? Oh, we lost Nurse Tabitha. I'm not sure what happened. I was going to ask if she wanted to add anything she wanted to add to that. Let's see if she able to make it back. But Brother Moses,
I know she'll be back. Yeah.
Oh, okay. But like I said, next week, we got our hands full because there's 7 more tasks that are attached to starting outpatient hemodialysis for the very first time. And so if you're just tuning in, welcome to Kidney Hub East Africa. I am Steve, the kidney nurse, and my co-host is Brother Moses Kennedy, also known as the Kidney Ambassador, and he is broadcasting all the way from Kisumu, Kenya. Now we have Nurse Tabitha back. Thank you, Nurse Tabitha, for coming back. And as I said before, you got disconnected. Was there anything you wanted to add to that discussion that Brother Moses talked about when it comes to patients in the US or UK that may take their treatment for granted, meaning not completing all their treatment, not going, skipping treatment, maybe refusing certain meds that are paid for by government insurance, to where patients in Kenya and maybe other parts of East Africa are subjected to paying for medicine that's desperately needed out of pocket instead of being paid for by the government. Anything you wanted to say on that?
Thank you very much, Steve. This week we are mourning one of our kidney hero. He's called Emmanuel Gitao. He has been having, he started dialyzing like 23 years ago. I've known him personally. He had even written a book, and the Renal Patient Society is mourning his demise. To add on whatever my brother Moses has said, I say avoid herbal medication, avoid religious addiction. What I mean is you go get prayed for, and then a pastor tells you now you don't need this, stop medication, throw them away. I know there are those patients who have followed, they have thrown away the medication, especially when someone had a temporary catheter. I remember seeing one patient being prayed for, and the catheter, he was being told, this one you just need to remove, and it even did not have a bandage. Remember that catheter is like your lifeline. So just take care of it very well. And the way I've said, avoid that religious addiction. Unless the doctor has confirmed to you that you don't need treatment, kindly follow your routine treatment. It's very important. Religiously take your medication. If you are diabetic, take your medication as prescribed by the doctor. If you are hypertensive, take your medication as prescribed. So that there are other things that can be affected by you having diabetes and hypertension, like your cardiovascular, your eyes also can really get affected. So many other systems of the body can get affected, not only the kidney alone. So I say kindly take care of it, and please do not prescribe yourself one dialysis, as in going for dialysis only once a week. If the doctor has not said come for dialysis once a week, make sure it is twice or 3 times as the doctor has prescribed. Thank you very much, Steve, for having me in this session. Thank you.
We appreciate you. Thank you. Very well said. So as we hold on, let's see if we got any questions or answers before we leave. We got Lawrence Hurst. He's from the UK. Thank you, Lawrence, for watching. We appreciate you watching. He says, hi, Stephen, Moses, and Tabitha. A lot of medications we no longer use cannot be given or sent, have to be returned to pharmacy patients. Information is vital for dialysis and transplant about taking meds. And he is right about that in so many cases, because here in the U.S., I mean, I've seen doctors who said that they were taking expired medicines back to Nigeria or maybe Cameroon. And you had to look at that to see I'm not a pharmacist, so I can't speak on the efficiency of expired medicine and how long shelf life and the effectiveness of a medicine that's expired. So, I mean, he's right in so many cases, unless I have someone like a pharmacist here to pretty much speak on that. But thank you for joining the show, Lawrence. I appreciate you, and I hope your transplant is doing well. He's had transplant over in the UK. He's on Facebook, shares his journey as well. But in general, when most people start dialysis, they go through a process from, when they go to outpatient, sign in consent forms allowing the facility to perform the treatment, to get your weight, getting your vital signs, starting treatment, going through the process. Some patients may experience nausea, vomiting, dizziness, cramping, itchy. some may not. Then the treatment is over. There's post vitals, your weight, temperature, blood pressure, pulse, and then you leave. And then if there's any issues, post vital signs like low blood pressure, cramping, or temperature, those issues are usually addressed. Patient get off dialysis and have a temperature of 101 or 100. We're going to call the doctor, especially if they have a catheter. Patient come off and they're below their baseline blood pressure, maybe 80, 70. Some places they may recannulate, put a needle back in, or hook up fluid to the catheter and give them a saline bolus, what we call it, extra fluid. And once we do that, next thing you know, we take the blood pressure and it's in range. So this is definitely a great topic that impacts not just brothers and sisters in East Africa, but all across the world that's dealing with dialysis. So as we get ready to head out, Nurse Tabitha, anything you want to depart with, any words of wisdom you want to depart with before we end our show?
Thank you very much, Steve. I keep telling my patient that all the machines work the same. The principle is the same. Therefore, they should not even be afraid to go and dialyze in that other unit. And even as you are sharing your experience and we are sharing our experience, and Moses is also sharing his experience, you can see there's a place where they merge. So do not be afraid to seek help in that center that is near you so that life can continue. Thank you so much, Steve.
All right. Thank you, Tabitha. Brother Moses, any words that you want to leave with before we end the broadcast?
Yes. Let me speak to those who are beginning dialysis today, tomorrow, or are currently diagnosed and are on dialysis. It is a journey that will not end today. It is also a journey that might take you long. So get prepared that as you take the journey positively, then you will achieve a better outcome in managing your condition. So never lose hope. Keep fighting, and that is why we are called warriors. So keep fighting and be positive towards your treatment. Then lastly, seek knowledge. Then all shall be okay. Thank you so much.
Thank you, Brother Moses. And y'all can find Brother Moses on TikTok, Kidney Ambassador, Facebook, the Kidney Ambassador. Tabitha, you're on Facebook and TikTok, or what social media could people find you at if they wanted to follow you?
On Facebook, yeah.
Okay.
I'm on Facebook.
You're on Facebook?
Yeah.
Okay, great. And so we're going to return next week and finish this discussion on your first hemodialysis, what to expect. So, Brother Moses, Tabitha, thank you so much. I'm going to drop you down. I got a few words I want to say, and then I'm going to end the show. But thank you, Brother Moses. We'll see you next week. Sister Tabitha, we'll see you next week as well to finish this discussion, your first hemodialysis treatment, what you need to know. All right. Brother Moses, I'll be talking with you later today. And Tabitha, thank you so much. And I'll talk with you soon, okay?
Thank you.
All right.
Thank you so much.
All right, brother. Thank you, Sister Tabitha. So this was a great show. We definitely appreciate everyone tuning in and watching. So tonight at 8 p.m. Eastern Standard Time, USA, will be the first broadcast, the first episode of Dialysis in Life with Steve the Kidney Nurse. And my guest is going to be D. Mill, kidney warrior and group administrator of Dialysis and Dating on Facebook that has a group membership of 3.5 thousand people. So if you're looking for a date and you want dialysis, visit that group. But come back tonight on the first episode of Dialysis in Life with Steve the Kidney Nurse. We want to thank you. That's going to be 8 o'clock Eastern Standard Time, USA. We want to thank everyone for coming out, supporting, and watching Kidney Hub East Africa with Steve the Kidney Nurse and Brother Moses Kennedy, also known as the Kidney Ambassador. This was a great show. We want to thank you. Thank you, PTs, for coming by. I want to thank Living Life 4010. We appreciate you, Lawrence. Thank you for coming by. Everyone else who stopped by and left, again, we definitely appreciate you. We see you soon. And again, don't forget to tune in tonight, 8 p.m. Eastern Standard Time, for the very first episode of Dialysis in Life, which is a weekly show. I think London is, you may be 8 hours. It may be in the wee hours for you, Lawrence. I think it's 6 hour time difference. So maybe like about 4 o'clock, something like that in the morning for you. But anyway, thank you, everyone. We'll see you soon. Peace and blessings. And we'll see you tonight if you come by tonight. Until then, we see you next week on Kidney Hub East Africa. Stay blessed and encouraged. Peace.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.